All right, next case from consult. So, older gentleman, diffuse rash. So, what are you seeing here? You're seeing diffuse pink papules and plaques with studded vesicles and bullae. And so, in terms of attacking a vesicular bullous disease, you know it's epidermal, right? There's something happening in the epidermis. Here's where you want to expand onto the level of the split. If it's superficial, um, you're thinking about something like pemphigus vulgaris, pemphigus foliaceus, perineoplastic pemphigus, etc. If you're starting to see that it's a firm bullae, then you know that it's subepidermal, and there's only so many things that could be: bullous pemphigoid, bullous lupus, linear IgA bullous dermatosis, epidermolysis bullosa acquisita, anti-P200 pemphigoid, etc. And really putting it into one of those categories will get you to the diagnosis. So what are you seeing here? Diffuse erythema. These bullae are tense. So obviously this patient has had some of them pop. They're even tense bullae are going to pop over time. But by and large, these are very, very tense bullae. So you know this is a subepidermal blistering process. From there, you just have to figure out with biopsies, histopathology, DIF, and serologies, either like ELISA or indirect immunofluorescence. And this turned out to be bullous pemphigoid. But the key is looking at this, you don't need to say this is bullous pemphigoid, but you're going to say this is subepidermal blistering disease, and then you're going to say it's BP, EBA, LEBD, P200 pemphigoid, etc. You know, there are some other subepidermal blistering diseases I would not want you to say in this differential, like porphyria cutanea tarda or pseudoporphyria cutanea tarda, because those are very non-inflammatory. You're not going to have all this background of erythema. Next case, I actually just saw this patient last week, transferred to our hospital for diffuse erythema with scale. I cut off the picture of his face and arms, but it's pretty much head to toe. And the key here again is not getting the diagnosis, it's looking at the clinical syndrome. And you have a patient who's diffusely erythematous, has diffuse scale. We call this erythroderma, you know, a redness of the skin. And erythroderma, when someone is erythrodermic like this, has a broad differential, probably most commonly psoriasis, but then you think about your dermatitis, atopic, contact, seborrheic. You want to worry about mycosis fungoides. Think about cutaneous T-cell lymphoma as well. Drug, there's idiopathic erythroderma, and those are probably the main causes here. So erythroderma is very hard to approach. It's hard to diagnose, but what you want to do when you see someone who's erythrodermic is you want to look head to toe extremely thoroughly at the face, inside the mouth, at the nails, at the palms, at the soles. You're looking for any secondary features that might show you the primary dermatosis. So if you see, you know, classic plaques of psoriasis on the elbow, then maybe it's psoriasis. If you see eczematous papules in the AC fossé, then maybe it's eczema that's gone bad. If you have crazy amounts of seborrhea in the beard and scalp, maybe it's seborrheic dermatitis. So it's hard to deal with because when patients become erythrodermic, a lot of the features become kind of blurred. So most patients with erythroderma have ectropion. They'll have palmoplantar keratoderma. They'll have nail changes. So at this point, it's really hard to diagnose these patients. So you do want to biopsy, probably get a peripheral flow, and try your best to get to the diagnosis. And we ended up with PRP as the diagnosis for this patient. Next case I also saw last week on consults. I absolutely want you to burn this picture in your head because nothing else really looks like this. So this was an immunocompromised patient. Can't actually remember why anymore. Maybe on chemo, something like that. So severely neutropenic, presenting with this dark black eschar. So dark black eschar, mild surrounding erythema. What are you thinking here? You're thinking badness. Why? Because eschar represents death. This is epidermal necrosis. The skin is dying because something deep to this is killing it off. So when you see this type of bullseye, well-demarcated circular eschar, it's almost always infection, and it's usually angioinvasive fungal infection. And it's one of those things that you've seen a few times and you never forget this, and this ends up always being what it is, and that's what this was again. So we biopsied this. There were numerous fungal organisms, and it actually grew rhizopus, so one of the species in the mucormycosis or mucormycosis family. So this patient was urgently started on amphotericin and got diffuse debridement. This is a cool case that I have 30 seconds to wrap up before I'm cut off again. Another hospitalized patient, numerous annular plaques like this. What I thought was really cool is that they have these studded pustules on top. So numerous annular lesions with studded pustules, you're going to be most likely in an infectious category, and this was actually a bullous dermatophyte infection. So absolutely teeming with trichophyte and rubrin. So cool case. We thought at first it was GA because there weren't a lot of epidermal changes, and then we saw the pustules and biopsied it, and that helped us render the diagnosis.